My name is Katie Merrill. I'm the Director of Rehabilitation Services here at the Office of Mental Health, and I'm joined by two additional staff from the Rehab Services Unit, Steve Roman and Stephanie Rodriguez, and I believe Danielle Olson from OASAS is also here. We are here to talk about person-centered planning and documentation as it relates to core services. If you are at all familiar with the operations manual, then hopefully all of this information today will be a review or a refresher and an opportunity for you to seek clarification or ask questions. I have just put links in the chat box to the operations manual, to the core site overall, benefit and billing guidance. So as questions come up or as we reference different guidance documents, I just want you to know where you can find those. All right, next slide. So I'm just briefly going to go over our training objectives today, and then I'm going to turn things over to Stephanie. So today we're going to talk very broadly about the principles of person-centered planning and practice. There's a lot more training available on this, and in fact, it's actually a required training for core services moving forward, and has been under BHH CBS as well. But we want to make sure that everyone here today is starting from the same understanding of what person-centered planning and practice are. We're going to highlight the key changes in documentation from BHH CBS to core services. So if you've been in that operations manual, then you know that we've defined what a case record or a chart is, and we've said exactly what you need to have in a case record so that when we come out and do oversight and monitoring visits, we're seeing exactly what we need to see, and everyone has the same understanding of what documentation is required. So we're going to talk about those today, and we're going to highlight what is new or different from BHH CBS. And we're also going to introduce the requirements for a core individualized service plan or ISP. And this is important because under BHH CBS, the ISP was very strongly linked to the BHH CBS plan of care driven by the care manager. Whereas with core services, it's a bit more of an independent document, and we want to make sure that you understand all of the required elements that need to be in that ISP in order to comply with the service standards. So with that, I'm going to turn it over to Stephanie. You can go to the next slide.
Good morning, everyone. Thank you, Katie. My name is Stephanie Rodriguez from the Office of Mental Health, and I'm going to be taking you through person-centered practice and why it's so ingrained in core services. Next slide, please. So, what is a person-centered practice? It's partnering with and engaging a person in a way that honors and respects their unique values, preferences, strengths, needs, and any barriers that they may have at the time. Next slide, please. Now, a person-centered planning, or PCP, is the way in which we assist people who need core services and the support they need to construct and describe what they want and need to bring purpose and meaning to their life. Next slide, please. So, person-centered planning and core. Person-centered planning is all about building a roadmap to recovery and not just signing the person up for services. It provides an opportunity to build an alliance or a friendship to collaborate in developing goals and planning for supports and services. Person-centered planning is strengths-based and focuses on the person's values, preferences, and goals. And person-centered planning also strengthens the voice of the person. It helps them build resiliency and promotes recovery. Next slide, please. So there is a person-centered component in core. If you look in the operations manual, which Katie was kind enough to link in the chat, each service begins with a new component, which is called person-centered assessment. And this new component demonstrates the commitment to person-centered planning and practice in core services. It's also an opportunity to capture time spent through a billable service component. Next slide, please. So it's all person-centered planning is all about working with, not for the individual. So before person-centered planning, there was a very clinical model. And if you're newer to the field, you probably never had a chance to experience or see the clinical model. But in the not so distant past, the clinical model focused on treatment of behavioral health symptoms, few personal outcomes. There was very large service groups and long lengths of stay. But with person-centered planning, the focus has really shifted to improving the quality of life for the person and focusing on their recovery goals, addressing any barriers that they may have, and working toward a meaningful recovery, whatever that may be to the person. Individualized recovery focused interventions, and shorter lengths of stay because they're based on the person's needs or preferences, not just signing them up for any service. Next slide, please. And when talking about person centered planning, I love to always discuss this quote, and it's by Dr. Mary Ellen. And it says, all people grow through taking positive risks, and that we need to support people in making life and treatment choices for themselves, no matter how different they may look from any traditional treatment. Allow the person to build their own crisis and treatment plans. The person should have the ability to obtain all their records and access information about any medication side effects they may be taking. The person should have the right to refuse any treatment and choose their own relationships and spiritual practices, and be treated with dignity, respect, and compassion, and create the life of their choice. Next slide, please. And with that, I'm going to pass it over to Steve, who's going to take you through the core case record.
All right, next slide, please. Thank you, Stephanie. So we're going to start out talking about the transition and documentation requirements, a bit of background here. Documentation standards for HCBS really have been poorly understood. We've done a lot of oversight and monitoring reviews over the past couple of years, and there's really been a lot of inconsistency in the quality and content of individual case records. So even though this has improved over time, we've done a lot of outreach, we've done a lot of technical assistance with programs, there's really a clear need for guidance from the state. So the operations manual includes clearly defined, standardized documentation requirements. And what I'm going to go through in the next few slides, very much of an overview, but it's important to spend some time in the operations manual. So we're going to expand on some of these, the core case record in following slides. Again, very well explained in the operations manual. So these are the requirements of the core case record. Documentation of a service-specific intake and evaluation. And I can't stress that enough, service-specific. It needs to be specific to the core service and includes goals, strengths, resources, and barriers. The LPHA recommendation, which is the determination of medical necessity. The individual service plan, that's the initial service plan and the updates. The ISP review summaries, which is something new. We're going to talk about that some more in slides. And it's also in the operations manual. Documentation of service encounter notes. I'm just going to simply refer to them as progress notes. Non-billable notes or contact notes. This is something new that we're going to talk about. Signed consents, other notices. So that can be, grievance policy, rights and responsibility, complaints, and another new component of the core case record is the discharge summary. And of course, agencies you can include to choose additional documents in the case record. But when we come in to look at your records, this is what we're going to be looking for. Next slide, please. Intake and evaluation. So this is really important. This is a person-centered process that engages an individual in the discussion of their recovery goals, their strengths and resources, their barriers and needs, and their individual's preference for services, days, times, the staff they want to work with, and how the core service will be used to support the attainment of their goal. So a very important process. Intake and evaluation, doing that good work up front is really going to drive your service provision. So it's important to spend some time engaging in this person-centered process. And as outlined in the operations manual, the intake and evaluation process is conducted by a member of the staff qualified to provide the service. Next slide, please. Now, what sort of documentation are we looking for in the intake and evaluation process? It's documented in the individual's core case record or progress note. It includes a description, a summary of their goals, and again, strengths, resources, barriers, and needs. This intake and evaluation process results in the initial individual service plan, the ISP. It's completed within 30 days of the first visit or 5 sessions, whichever is greater. And what that really means is you have some flexibility. So as an example, if you have someone that's a little bit difficult to engage, you would have the flexibility to extend that intake process longer than 30 days. You would be able to go up until that 5-session limit is met. So we've added in that flexibility with the intake and evaluation process. Next slide, please. The LPHA recommendations, something new for CORE. If you've been with us on all of our monthly regional calls, you should be very familiar with this concept. It's outlined in the operations manual. We do have a state issued template for the LPHA recommendation. It can be obtained as part of the initial referral packet, or the LPHA recommendation can be done during the intake and evaluation process. So the entity making the referral may include the LPHA recommendation, or you may do it internally, but it must be completed and in the case record before completion of the ISP. So we're also going to be having a training on that. There's more information in the operations manual. I'll try not to say that 100 times today. Next slide, please. The ISP, the individual service plan. Person-centered services really start with an ISP that's created with the individual's own language and is consistent with their values, cultures, beliefs, and goals. You know, in the old days, we used to do treatment plans, and we used to basically, as practitioners, we would establish goals for people. The ISP is really person-centered, person-driven. It's very important that it's in their language and incorporates their values, beliefs, and goals. So it's a document done with the person. It also documents the frequency, intensity, scope, and duration of services. And it focuses on what the individual is saying and framing of their problems and solutions. Also, again, taking into account their strengths and resources. So this is just a very important way to start the service delivery process. The ISP needs to be important to the person. What are the goals of that person? What are their strengths? What are their barriers? So important work to be done right up front. Next slide, please. Progress notes. So this is something in the core manual that we've outlined what the expectations of progress notes should be. They should include the following elements: the name of the person, what service was provided, the date, where it was provided, what was the modality, in person, was it done by a telehealth, was it a collateral contact? That's all your basic stuff. Duration of service, including start and end time. Very important here. Description of interventions to meet the ISP goal, including a narrative description of staff action. So it's really important in doing your progress notes. The staff needs to document the work that they do. I see too many cut and paste progress notes, too many 1 and 2 sentence progress notes that really don't describe the good work that your staff are doing. So what is the intervention? What goal was addressed? What objectives were addressed? What did the staff do? Really important. Please don't do cut and paste progress notes. Lastly, the name, qualification, dated signature of the staff person delivering the service. Next slide, please. So just to expand on this some more, the description of the intervention, the work that the staff are doing, it should clearly demonstrate the service component used to support the individual. And this is something I talked about in the previous service specific trainings. It's really important to understand the service components of each of the 4 core services, what language is used, what are allowable interventions. Really spend some time in the operations manual, making sure you understand those terms, making sure you understand the services. So what were the staff actions? So a narrative of the staff actions. What did you do? What did the staff person do to move the person forward. Again, give yourself credit for the work that you do. Lastly, what worked? What didn't work? How did the individual respond? This is really, really important as you think about it. Also a great opportunity for utilizing concurrent documentation. You can do your progress notes with your heart member present. It's a good opportunity to really review what you worked on. What did they think about it? Was it effective? Was it not effective? So a great opportunity for concurrent documentation. Also a great opportunity to take back to your clinical supervisor. If you're feeling stuck, if you're feeling like the goal isn't appropriate, the interventions aren't working, this is great notes to have to yourself to bring back to your supervisor. Next slide, please. So we just wanted to do a couple slides about examples of what some good notes look like. You'll see the check boxes at the bottom. So here's a PSR note, and just going to read through it very quickly. Today, we discussed Amy returning to work. She was concerned about her anxiety and how this would inhibit her ability to work. We discussed coping strategies like deep breathing exercises and mindfulness. The staff person modeled these strategies for Amy and they practiced. Amy agreed to try to use these coping strategies and is also considering a career coach to assist with her applying for a job. So kind of a next step in there as well. So this progress note, it's brief, but it really demonstrates those three check boxes, demonstrating service components, education and skill building, the staff action. They did some modeling, they did some practicing, the individual response, the client agreed to use the coping strategies. So these interventions worked. It says right here, the client is going to give it a shot to try to use these coping strategies, and also looking at a career coach. So looking at community resources. Next slide, please. So another example, and this is for family support and training. Today, we met with Joe and his daughter to discuss barriers to their relationship, including the need for boundaries. After a long discussion around how healthy boundaries can increase trust, Joe agreed to boundaries set by his daughter, including asking permission by text or phone before coming over. Both Joe and Mia seemed responsive to ongoing skill building. So again, this is a brief progress note, but it checks all those boxes. Demonstrating the service components, again, education and skill building, the staff action, education around boundaries, and skill building on how to set those boundaries. And, lastly, the individual's response, they're putting it into action and responsive to ongoing skill building. So again, this note demonstrates effective interventions. It's showing what the staff did. So again, it's brief, but it covers the necessary bases. Next slide, please. Non-billable notes, super, super important. I know billing and documentation can be a drag. It's extra time, but I can't emphasize how important it is to have good progress notes. When someone comes into your program, whether that's an oversight, whether that's an audit visit, could your progress notes be audited? Could your notes be subpoenaed in a court case? It happens. It's really important to have good progress notes, including non-billable notes. This really fills out the picture of the work that you're doing with the person. So non-billable contacts are an important part of the individual's course of service. Too often, I just see progress notes around service delivery, but it doesn't give you a good picture. Again, as staff people, as supervisors, you need to make sure you give yourself credit for all the work that you do. So non-billable notes document any information pertinent to the individual service. If so, outreach and attempts to re-engage. Oftentimes I'll see progress notes that there's a 5-month gap in services. What happened in that 5 months? We have no idea because there's no notes documenting outreach attempts, calls to case managers, calls to other practitioners. Document that work. So these contacts should be documented in a contact log, a case note, a non-billable progress note. That's really up to you. Things like routine appointment reminder calls or texts don't need to be documented, but again, a letter attempting outreach for a disengaged individual, things like that should be documented. It's kind of a, cover yourself strategy as well. Again, to use that example of seeing that a person didn't have contact with their client for 5 months. What happened in that 5 months? You want to document your outreach efforts, who you called, things like that. So very, very important. Next slide, please. Discharge planning. So this really, discharge planning, we always say this, begins at intake and is ongoing. So really talking with the person about their progress, talking with the person about their goals. What does success look like to them? What are they hoping to get out of the service? What happens next? So discharge planning should not be this abrupt thing of the person met their goals and I'm gonna discharge them, and we don't see anything about it in the progress notes prior to the day that they're discharged. So really start doing this planning at intake. Document the work that you're doing towards discharge planning, especially as people make progress towards their goals. Conversely, if they're not making progress, document that as well. It's critical to the individual's recovery process, thinking about a transition to lower levels of care, transition from paid supports to natural supports. This needs to be planful. It cannot be abrupt. Any sort of jarring changes like that can really disrupt the person's progress and perhaps cause a regression in their project in their progress. So no surprises here. Discharge planning involves collaboration, communication. That's with the person, and that's also with their collaterals. If they have a case manager, if they have a clinician somewhere, really doing that discharge planning with everyone involved. You don't want there to be any surprises. Discharge planning also involves whatever services and supports they will be referred to. So if they are no longer receiving core services, are there community supports they're being linked to? What other professional supports are they still working with? So really good discharge planning sets the stage for future success. Next slide, please. The discharge summary. This is something we're going to be requiring for core. Pretty simple. Completed within 2 weeks of discharge and includes the date of discharge, the reason, summary of progress or lack thereof while receiving services, and then also the date. So really just a snapshot of how long they were in services, what goals they worked on, what they achieved, what barriers they continue to need to address, what supports were they discharged to. It should be shared with the managed care organization upon completion, and with consent, this summary can be shared with the health home care manager, other providers, and it's really this good collaboration, this good coordination is amazingly helpful because it's going to facilitate the people that will be working with your client. They're going to be getting this good snapshot of where things are, what you worked on, what worked, what didn't work, what goals were addressed, what still needs to be addressed. And with that, I am turning it back over to Stephanie, I believe.
Thank you, Steve. Next slide, please. So before we can go into core and the ISP and the requirements, there's some key concepts that we need to review. The first of which is a recovery goal. And this is a statement that expresses the person's desire for positive change and improvement in their lives. And it's ideally captured in their own words. So this would be the I statements. I want to feel better and manage my symptoms. I want my own place to live. I want a full-time job. I want to complete my education, and so on and so forth. Next slide, please. There's also objectives. So this is something the person will do or accomplish as a step toward achievement of whatever goal they identified. So the objectives should address identified barriers to the goal and are meant to drive the ISP forward. And objectives should answer the question something like, how will you achieve that goal? What steps are you going to take? When will you take them? And who do you think will help you? Scope, services, or interventions, and these are the activities and services provided by core staff that help the person achieve any identified objectives and goals they would like to work on at that time. Next slide, please. I love this diagram, and this is really represents how objectives and interventions work together. So the objective is what small steps the person will do or accomplish to support their goal. And the intervention is how will staff support the individual? So as you see, we have a little man walking up the stairs, and each one of these stairs represents an objective. And at the top of the stairs is the recovery goal of what they're trying to get to. But not featured here is really any handrails. And I've gone up the stairs and I know it's not uncommon that tripping or slipping is natural. And the possible tripping in this represents relapse, which is a natural part of the recovery journey. So the handrails in this could be something like a relapse recovery plan, so that when the person starts to slip or maybe begins the trip, they can grab onto the handrails and stop themselves. Or if they do have relapse and maybe they fall down a couple steps, they can help pull themselves back up and get on track to whatever recovery journey is meaningful to them. Next slide, please. So if you didn't like my little diagram, I like to further outline it with templates. So the person's recovery goal would be, I want to have a better relationship with my daughter. And the objective to that would be, well, they're going to enroll in a parenting class so that they develop skills to have a better relationship with their daughter. If they want to remain living independently, again, in that I statement, they're going to learn maybe how to manage their finances or pay rent on time so that they can maintain their apartment if that's something they're currently struggling with. And again, they want to get a promotion to maybe a shift manager at work. It's great, they have a job, but maybe they need to develop those management skills so that they can earn that promotion. Or maybe they're struggling with their diabetes and they're not taking medication at the time and they're not interested in taking medication. The objective could be they'll increase their knowledge on managing the diabetes and they could work with their care coordinator and attend doctor's appointments to learn this information. Next slide, please. So, how do you engage someone in person centered planning? And it really begins with just having conversations with the person and getting to know them, really moving beyond what just their diagnosis. And a question that I think really describes this process is, how would you describe yourself to someone who doesn't know you? It's also important to identify any natural supports in that person's life. And this could be family, including family of choice, friends, and community groups. And ask the person if they'd like to invite any of these people they identify as a natural support to their periodic ISP review. And when planning interventions in any modalities, try to find the balance between important to and important for. Next slide, please. So, person centered planning and risky behaviors. So person-centered planning is always the person driving the plan. Providers can suggest not to engage in any risky behaviors, but if the person chooses to, the provider should use self-harm reduction techniques. So if the person is, let's say, a really avid smoker, but they have no desire to quit, staff could maybe educate them on the risks of smoking, but signing them up for a cessation class wouldn't be appropriate if they have no interest in it. And a provider must be prepared to engage the person using self-harm techniques, as I just said. But if it's unavailable, they should be able to refer to outside harm reduction programs that provide these services. Next slide, please. And here's some quality indicators that outlined if you're on the person-centered planning process guideline track. So the person is engaged in shared decision-making process. The service provider shares the knowledge and recommendations with the person. that are necessary for the person to make meaningful, informed choices. So working with the person, not only making decisions with them, but making sure they understand their choices and the decisions they're making. Families of choice and significant others, or natural supports, as we talked about a few slides ago, are encouraged to engage in the planning and services. And of course, this is with consent of the person. So if they don't want anyone there, they shouldn't have anyone there. But if they do want someone there, why not? Service planning meetings are held at times and locations that are convenient for the person and not just for staff. And the person is supported in sharing any of their goals, needs, and preferences. Next slide, please. And as we've discussed, goals are written in the person's own words using I statements. And this process reflects cultural humility. So respecting the person's background, beliefs, values, and cultures. So if you're writing a goal about how maybe this person's Jewish and they like to attend services, you wouldn't say that it was important for them to attend church. I would say it's important for them to attend synagogue because that's cultural humility in that context. Written materials are provided in a way that is understandable to the person, again, making sure they understand what they're agreeing to and what their options are, and that the person's offered an opportunity to sign their ISP, and the person's offered a copy of their ISP. So whoever your host agency is, whether that be OMH or OASAS, there will be monitored quality indicators using the core service standards, and this is outlined during the oversight and monitoring process. And designated providers are encouraged to incorporate any of these indicators we just went over into their own internal quality improvement process and protocols to make sure you're staying on track, not only for the ISP requirements, but for person-centered practices. Okay, so the core ISP review. The ISP is reviewed with the person whenever there is a significant change in their life. And we'll go into more detail about what a significant change is on the next slide. But the significant change would necessitate a change to the frequency, duration, or scope of services, or maybe even the goal. If there is no significant change, the ISP must be reviewed minimally every 6 months. Next slide, please. So here's some examples of significant change, and this is not limited to, but here are some. Maybe attainment of a goal or objective. So if the person reaches a goal, it doesn't make sense to leave it on the ISP for 6 months. You can review it, update the ISP, and that resets the timer for the minimal 6-month review. Adding or changing the goals based on the person's request. And this is a nice flexibility that if the person signed up for a service and it's not working for them, or maybe they thought they were interested in, you can take it off the ISP without having to wait for a set time requirement. If the person moves to a new home or residential setting, a change in employment status or educational attainment. So if they had a goal about getting a job and they get the job, you can update the ISP and change that. Maybe a change in a relationship status or household composition. If they had a recent hospitalization and maybe they need some new goals added, or if there's just been no progress towards the goal and they want to get rid of it and try something new. Next slide, please. So the ISP review summary is documented in a progress note or a case note. The review is completed even if there is no updates or revisions needed. The ISP review must include the date of the review, the names of anyone present, a summary of progress made, and if there was no progress made, the reasoning for no change must be included in that summary, a description of the person's involvement in the review process, and a notation of any changes made or not made to the ISP. Next slide, please. And with that, I'm going to pass it over to Katie, who's going to wrap up and give us a summary.
Thanks so much, Stephanie. So I've been watching all of the questions come in, and I think that a few of these might be answered in my wrap up, but I do want to leave time for questions. So I'll move pretty quickly through this. Next slide. So I want to talk a little bit about collaborative documentation. If you have been with us for the last 4 trainings on the service-specific webinars, then you know that every service begins with a component for person-centered assessment, planning, documentation, and collaboration. That collaboration piece is so important because we want to invite staff and individuals to participate in collaborative or concurrent documentation. You may or may not be familiar with collaborative documentation, so I'll just go over it very briefly. This is a practice where the individual and the practitioner complete documentation together. It happens particularly with service plans and with progress notes, but any documentation could be done collaboratively. When you do collaborative documentation well, what that means is you have the person there with you and you are documenting what has happened, what the progress was, what the service or intervention was that was delivered, and how the person responded to it. When this is done well, you actually increase trust and rapport between the individual and the staff person. You support the ongoing person-centered planning process because this is a routine check-in with the person, that you are on the same page with them and everyone is in agreement about what happened that day, how the service went, their satisfaction with services, and what their progress is. And lastly, this is a recovery-oriented practice that keeps the individual in the driver's seat throughout their episode of care or throughout their rehabilitation services. So we want to make sure that individuals are fully aware of what's being written about them, how they are progressing, and that there's that transparency between the staff and the individual. Now, collaborative documentation is not required for core services. We actually do think that it takes some level of skill. And so some staff may be able to do this and others may struggle with this intervention. But if you do it with the individual, then it is billable under all 4 core services. So that's important to note. We would really like to see that staff who engage in collaborative documentation receive training and support from the clinical supervisor. All right, next slide. Continuity of care. This is where I wanted to address some of the questions that I saw in the chat box. So individuals who are transitioning from BHH CBS, CPST, PSR, family support, and peer support to core services need to be engaged in a person-centered planning process to update their individual service plan by May 2nd, 2022. That's the 90-day continuity of care period that we give providers and individuals so that they can take that time and use a couple of months right up front to really understand what are the differences between core and BHH CBS and what interventions might that person want to receive. Maybe they want to update their goal. Some individuals may have been in HCBS for a year or two now with a goal that was developed by a care manager that may or may not have understood the services. And so this is a really nice opportunity for just the staff person and the individual to talk about what do you want to get out of core and how can we get you there. The updated core ISP needs to meet the core documentation standards that are outlined in the operations manual. So if your template doesn't have all of those required elements, or if you were counting on the actual authorization to kind of count as an ISP instead of having a separate document, then you really need to make sure that you have an updated format or template that meets all of our documentation standards. It should include interventions that align with the core service definitions and components. So you should be calling out what it is under PSR that you're doing that makes it count as PSR or family support, et cetera. Individuals will be considered to have transitioned to core when their ISP is updated to reflect core. So that's kind of the point at which it's considered, okay, this person is 100% over in core services. And when that is done, when you have the updated ISP that meets all of our requirements, the provider is responsible for notifying the MCO that that individual has transitioned, and they'll do so using the service initiation form. It's on our website. It's linked with the other documents that I posted. So you can find it in the benefit and billing guidance. And I believe we also have a standalone form on our website. It's very brief. It's really just demographic information and kind of confirmation that the individual is receiving core services. So we did not want it to look like an authorization process. It's just your way of communicating to the MCO that this individual has transitioned. It's the exact same form that you would use for a new intake to core services. Let's see, all new intakes or referrals to core services will require an LPHA recommendation before the end of their intake and evaluation period. So individuals who are transitioning from BHH CBS to core don't need that LPHA recommendation. Their eligibility is presumed based on the fact that they have been receiving these services. But if you're intaking a new client, or if you're taking someone from perhaps BHH CBS intensive supported employment over to core PSR, you do need that LPHA recommendation. And lastly, your EHRs will likely need to be updated to reflect these new requirements. We will be providing updated tech specs that you could provide to your vendor, and we're strongly encouraging providers to work together with other core providers who use the same EHR vendor to advocate for those changes to be made, hopefully for free or at a very reduced cost. All right, next slide. Now, I want to just put this in here because I think it's important. Person-centered planning is critical for both HCBS and core services, but today's training and all of those documentation requirements that we talked about are specific to core. Nothing has changed in the BHH CBS provider world. So if you are providing habilitation, education support services, pre-vocational services, transitional employment, intensive supported employment, or ongoing supported employment, you will still use the existing provider manual, the existing service standards. And we do have a recorded webinar, I believe it's from 2018 on the MCTAC website, that focuses on this exact same topic of person-centered planning in the ISP. So there's a link in the slides. You will be provided with the slides. So if you're continuing with HCBS and you're wondering what those documentation requirements look like, please check out the 2018 training. There have been no changes for those services that are remaining in HCBS. All right, next slide. So I'm just going to wrap us up really briefly here so that we can get to those questions. The operations manual outlines all of the new documentation requirements and recommended best practices with an emphasis on person-centered planning and person-centered practice. Please read through it, memorize it, do whatever you need to do to make sure that you understand what the new requirements are, what the new service standards are. When we come out for oversight and monitoring reviews, you will be held to these new standards for core services. Person-centered planning is such an important tool for engagement, empowerment, and recovery, and that's what core services is all about. Each core service now includes that person-centered assessment planning and documentation component that I talked about, creating a new billable opportunity for staff to engage individuals in the person-centered planning process. And just as a reminder, person-centered planning doesn't end as soon as you have that initial ISP. It's not just something that you do as a part of intake. It's really something that you do in every single visit with an individual. And we have designed these services to promote that person-centeredness and to make sure that it's a billable activity. All right, so next slide. I think with that, we can answer some questions.
Excellent. So thank you, Katie, Steve, and Stephanie for a great presentation. We do have a number of questions that have come in, and please continue to submit your comments and questions, and we have some comments as well. One thing I just wanted to underscore, both I think Katie and Steve talked about concurrent and collaborative documentation, and especially for core during some of our other presentations that's recorded and available. We also talked about core being able to provide as kind of a bundle of services or a team approach. It's of course not required. There could be individual services and standalone, but if you do provide them more as a bundle approach for some individuals, that collaborative and concurrent documentation is really crucial. So your colleagues who are providing other services, can work together, and that's one way folks can communicate as a team about what's kind of working, what's not working, and how best to serve that individual. So I just wanted to add that into the mix about why in general collaborative and concurrent documentation is important. I do want to say, as I think I've mentioned earlier, that what we're going to do is try to get to as many questions as possible. We will be focusing on today's topic, which was again, person-centered planning and collaborative documentation. So I'll be picking those questions first, and then we can move on to, if we have time, to some of the other questions from that perspective. So we did have a question about templates, and I think Katie, you might have just touched on it, but just wanted to confirm. I don't think the state is looking to produce documentation templates, but rather really looking to make sure that whatever the templates the providers create meet the requirements. But just wanted to confirm that's accurate.
There are two templates that the state has issued that will be required. You can't change them. You can't do your own thing. Number one is the provider service initiation template. This is on our website. which I linked in the chat box. The second is the LPHA recommendation form, also on our website. And I'm going to put the direct link in the chat box because I know that was just requested. Those two you are required to use. Everything else, you just need to make sure that whatever you develop as an agency includes all of the required elements.
Yep, definitely. Yeah, so we have another couple of comments about using different names in the progress notes, because I think the example said both the individual's names and also from the clinician side, what do you do? So just confirming that it's okay to use the name of the individual you're providing services to, just like
Yeah.
those in examples.
Sure, absolutely. As was in the examples, we would love to see the individual's name in their chart, and particularly if you're engaging the person through collaborative documentation, or if you have someone who maybe requests a copy of their record, which people have the right to do, how empowering would it be to see your name in that chart and to know that you were seen? And I just think that that's really a best practice, and that's what we would like to see is the individual's name in the chart. And to the second part of that around staff, you don't have to say this writer or the practitioner. You don't have to talk about yourself in the third person. If you are writing a note about an intervention or a service you delivered, you can say I.
Got it. Thank you for that. There is a question around, folks sometimes disengaging, and it's, and maybe some of the discharge planning or discharge summary that was talked about might be difficult to document. So any thoughts on if you don't have those questions, right? Let's say the person did fully disengage, you're, weren't able to really have that quote unquote proper discharge, if you will. Any thoughts on what might be documented in that discharge summary, for example, or that discharge? Yeah.
So I know that in doing a lot of chart reviews as part of oversight, we did see some examples of individuals who maybe didn't make it very far past an initial intake, or they became disengaged for other reasons. So you still need to do a discharge summary. There may be fewer details, but the important thing to know is were they provided other resources? Were they referred elsewhere? What efforts were made to re-engage them? Maybe you sent a letter to the best known address for them. Maybe you left voicemails. Every agency should have their own policies and procedures around engagement and disengagement, and you should be following those policies and procedures. So when we come out and do a chart review, we're going to read those policies and procedures, and then we're assessing whether or not your staff are following what you have laid out as appropriate. We would really encourage staff who are experiencing an individual who is becoming disengaged or who is disengaged to work closely with their clinical supervisor and to document as much information as they can in that discharge summary.
Excellent, thank you. All right, so we have a number of questions about different trainings and slides and so forth. So I'm going to try to combine them all together, and I would invite our state partners to jump in here as well. So one is, again, this presentation is being recorded and the slides will be made available to all. There's questions about previous webinars and so forth. So we have all of the other webinars are on our MICTAC website, but I know OMH also has a dedicated site or page for core as well. So please feel free to utilize, again, all of those previous presentations have been recorded and made available, so you should be able to find them. There's also a number of additional trainings that are being planned. I know there was a question about, care managers, and so there's actually a training this month on it, and I think we might have over 700 people already registered for that training in core. So there is a lot that has been done. More is coming on many different levels. And again, just strongly encourage folks to utilize both the MICTAC and the OMH website for extensive amount of information, both from all the links that were provided in the chat box, but also that are much more that's available out there. So I think that covers quite a few questions that we have around kind of trainings and so forth. There was one specific that I don't know if Katie or somebody wants to talk about, documentation and peer, and kind of making sure that, some of the documentation around peer maybe a little bit more specific, or if there's thinking about doing something specific to peer and documentation.
Yeah, I did see a question around basically the examples we gave, which were for psychosocial rehabilitation and family support and training, that some peers may not have the skills to write at that level, I believe was kind of where the question was coming from. So I really think that this is a significant area for the clinical supervisor to work closely with staff. We gave examples for psychosocial rehabilitation and family support and training, but if any providers feel like they need more technical assistance in that area, I would encourage you to reach out. I don't feel that the examples we gave were terribly clinical. I think that what we're trying to show is that you should document what it is that you did that's related to the individual's goal and how you helped further their recovery and how the individual responded to that. That's what we want to see in a progress note narrative. So we would really encourage that any staff person, whether they are licensed, whether they are unlicensed, paraprofessional, whether they are peer, that if they're struggling with documentation, then they connect with their clinical supervisor for coaching and support.
Excellent. Thank you for that. There was a question around ISP, and especially for agencies that provide other services and already have established ISPs with them. And I guess the question again around, does core have to be different? Can it be the same ISP that already an agency might have in their clinical record? And I would add to it, I don't think this was part of the question, but I think as a kind of integrated care, if somebody's getting core and other services from the same agency, is there an opportunity to combine that? I guess my thought would be, as long as it meets the core requirements that you guys presented, it should be okay. It's not about how it looks, it's more about the components of it. But again, just wanted to have you guys from the state to answer that.
Yeah, so a couple of thoughts there. Number one, you have to have the required elements, just as Boris said. So if the template that you're already using is missing, I don't know, the person's strengths, then you're not including all of the required elements because that is required to be on there. However, you can be a little bit creative. Sometimes EHRs give you like a narrative box where if you're missing one of the required elements, you could still include it by including an additional narrative. So what we're looking for is the content. It doesn't need to match up line by line and in the exact same order that we've given it. So we want to be a little bit flexible. If you already have something that's working well for you, just make sure that you're including all of those administrative requirements that are outlined on page 9 of the operations manual. Now, in terms of other program types, what we would look for is core services themselves could be included on a single ISP. If you have someone who's receiving 3 core services through your agency, you could do one ISP that includes all 3 services. If they're in a pros and they're receiving core peer support, then I would be looking for 2 different things. I'm looking for a pros IRP and I'm looking for a core ISP. So you can't combine like program types into a single treatment plan or service plan. But as long as it's all core services, you could combine them, for the purposes of simplifying things for the client and for staff.
Excellent, thank you. There was a question about timelines of these, core documentation requirements. So core is going live on February 1st, if I'm not mistaken. And I guess if you're starting to provide core services on that day, you would need to make sure all of your documentation lines up with that. Is that accurate, or is there a timeline? Is it also May 2nd or anything like that?
So for the ISPs in particular, you have until May 2nd. I would strongly encourage you to stagger the ISP reviews. So you might, if you have 100 people receiving services that are transitioning over to core, I would divide 100 people by 3 months. And so you might be looking at doing 5 or 6 ISPs a week as an agency, divided across your staff caseloads, whatever makes sense. You want to make sure that you're giving staff time to really have person-centered discussions. They can prioritize individuals based on who's really motivated to get a new service plan versus who might need a little more time to understand these changes and take it all in before they're ready to agree to a new service plan. So That's going to be a discussion with the clinical supervisor to make sure that you, over the course of those 90 days, get everyone transitioned over. All of the other documentation requirements, let's say you discharge someone in April, well, then you need to meet the requirements for the discharge summary in April. There's no phase in for anything else. Progress notes need to meet this standard effective February 1. All of those other documents that we talked about in the case record, everything needs to be in compliance February 1. The only area where you get a little bit of leeway is for individuals who are transitioning to update their ISPs.
Excellent, thank you. So just keeping an eye on time, we have 1 minute left. So Katie and our state partners, any last minute comment or question that you've seen through the chat that you want to answer? Again, you know, this, like as I said, the state is going to be getting all those questions and comments, but just wanted to give you know, kind of last chance or last question to answer.
Yeah, you know, I'm seeing so many questions and I would love to get to all of these. I would really encourage providers to attend the regional forums. If you're a current BHH CBS provider, then you should be getting those invitations through your field offices. Please join us there, ask these questions in that forum, or shoot us an email at adult-bh-hcbs@omh.ny.gov or picm@oasas.ny.gov. We would be happy to walk any provider through these issues. We want to make sure that you're getting the support that you need to make the transition successfully.
Excellent. Well, thank you for a great presentation, and thank you everybody for joining us. And as I mentioned, look out for more trainings to come, and please feel free to you know, go to our website for information that's already available. So thank you everybody, and take care.
Thank you.